This content is produced for educational purposes only. It does not constitute medical advice or legal advice. The clinical and legal information presented reflects publicly available case records, peer-reviewed literature, and published guidelines. Laws vary by jurisdiction. Clinical decisions should be made based on individual patient circumstances and current evidence-based practice. Case details are drawn from public court records. This is the cognitive autopsy from the Chartered Defense. I am Brian. With me, as always, Sarah and Paul. Today we are talking about back pain. Specifically, the kind of back pain that ends in paralysis. A patient presents to the emergency department with a dull ache in the lower back. It has been building for a few days, not sudden, not dramatic. The patient rates it maybe a 5 out of 10. They have a history of intravenous drug use. They mention a skin infection that cleared up a few weeks back. Today, it is the back pain. Before we go further, pause and ask yourself, what would you do? What is your differential, and how far down that differential would you look?
That is the question this episode is built around. Not what went wrong, but where did the thinking stop? Because the answer, in case after case, is that it stopped too early.
The emergency physician examines the patient. There is tenderness along the lumbar paraspinal muscles. Pain increases with movement. The patient denies leg weakness or numbness. Vital signs are within normal limits. No documented fever. The physician documents musculoskeletal back pain. Probable muscle strain. The plan, acetaminophen and ibuprofen. Return precautions. Return if pain worsens. The patient is discharged.
At this moment, if you are listening and thinking, that sounds reasonable, you are not wrong. That is exactly the point. The examination findings are consistent with musculoskeletal pain. There is no neurological deficit. The patient is afebrile. But here is the question that was not asked. Does this patient have risk factors for something more serious than a muscle strain? Because for this patient, the answer is yes. A history of intravenous drug use and a recent staph skin infection. Those are two independent risk factors for bloodstream seeding. And bloodstream seeding is the mechanism that creates spinal epidural abscess. The diagnosis on that first visit was not necessarily wrong, but it would have been stronger if risk stratification had been performed. That is what we are advocating for here. A complete assessment would have included a deliberate look at the risk factors and a conscious decision about whether further workup was warranted. Back pain is among the most common chief complaints in the emergency department. Typically, the fourth or fifth most frequent reason for a visit. And more than 90% of those presentations are musculoskeletal in origin. Our brains are pattern recognition systems. When we see back pain, we pattern match to muscle strain. That is not a failure of education. That is cognitive efficiency. It is how we manage high-volume clinical environments. But spinal epidural abscess also presents as back pain in more than 70% of cases. And here is the problem. The classic teaching triad, fever, back pain, and neurological deficit, is present in fewer than 8% of patients at initial presentation. 8%. That means if you are waiting for the triad to trigger your suspicion, you are potentially missing more than 9 out of 10 cases at the point where intervention still matters. That suggests we may need to reframe how we approach this diagnosis entirely. The triad is useful when it is present and it has high specificity, but as a screening tool, it is inadequate. It was never validated as one. And the patients who present early before the neurological deficit has developed are the patients who benefit most from early diagnosis. Those are exactly the patients the triad misses.
To put a number on the scale of this problem, A 2022 systematic review published by the Agency for Healthcare Research and Quality evaluated diagnostic error rates across the 15 most dangerous conditions seen in emergency medicine. Spinal epidural abscess had the highest diagnostic error rate of all of them, 56%. By comparison, stroke has a 17% error rate. Myocardial infarction, about 1.5%.
And the reason for that disparity maps directly to infrastructure. We have decades of pathway development for MY, troponins, EKGs, chest pain pathways. Stroke has NIHSS, CT protocols, thrombolytic criteria. Spinal epidural abscess has no equivalent. As of this recording, no major medical society, not IDSA, not ACEP, not the Society of Hospital Medicine, has published a dedicated clinical practice guideline for SEA. There is no standardized screening tool in widespread use, and so the diagnosis depends entirely on individual clinical reasoning, which means it depends on the cognitive habits of whoever is in the room.
The patient returns the following night. Different physician, different shift. The pain is worse. It radiates now. The patient is increasingly distressed. The new physician orders a CT of the abdomen and pelvis to rule out kidney stone. The CT is normal. The physician tells the patient it is not a kidney problem. The patient is discharged again. Return precautions. Return if fever develops.
Two things happened on this second visit that matter in litigation. First, CT is the wrong imaging modality for spinal epidural abscess. MRI with gadolinium is the gold standard. Sensitivity 90 to 95%. Specificity exceeding 90%. CT does not reliably detect epidural abscess. A 2025 analysis of delayed diagnosis cases in the legal literature found that every case they reviewed involved CT use instead of MRI. Courts are increasingly treating CT for suspected spinal infection as below the standard of care when MRI is available. And this matters for a specific reason. The CT order creates a timestamp. It tells the plaintiff's attorney exactly when the physician was concerned enough to image the patient, but chose the wrong study. That is a powerful exhibit at trial. If the correct study had been ordered at that exact moment, the outcome may have been different. We have seen this pattern in previous episodes. Ordering the wrong test does not show due diligence. It can actually suggest that the clinical concern was present and the appropriate follow-through was not.
The broader point is this. If a patient has back pain, take a moment to look for the subtle clues that this could be more than a strain. Intravenous drug use is a key risk factor, but it is not the only one. PIC C-lines, ports, hemodialysis fistulas, any chronic vascular access is a source of bacteremia, and bacteremia is the mechanism. If the source is there, the risk of spinal seeding is elevated, and CT is not going to answer the question. MRI is the study. Order the right scan.
Second, the return visit itself is a clinical red flag that the legal system recognizes. A patient returning with the same complaint, worse than before, should lower the threshold for investigation, not confirm the original diagnosis or look at a different organ system. And there is another dimension to it. The return visit also shows that the patient followed the discharge instructions. They were told to come back if the pain worsened, and they did. That compliance works in the patient's favor in litigation. Research published in 2025 in the Western Journal of Emergency Medicine found that 71% of patients eventually diagnosed with spinal epidural abscess had at least one prior healthcare visit in the 30 days before diagnosis. The bounce back is the rule in missed SEA cases. It is the most consistent feature of the failure pattern.
And notice what was not documented on that second visit. No neurological examination, no inquiry into risk factors, no mention of the staph infection from weeks earlier. The MRSA history was in the chart. It was available, it was not read. Now, I want to acknowledge something about that MRSA history. A lot of patients screen positive for MRSA colonization. Over time, providers can become desensitized to that finding in the chart. It is everywhere, but in this case, it was not just colonization, it was a recent clinical infection, and in the litigation, that distinction became central. A recent staph infection in a patient with IVDU history and worsening back pain, that combination is worth pausing on. It deserved more than it received.
The patient returns a third time. This time, there is leg weakness. It is progressing. The emergency physician orders an MRI. It reveals a large epidural abscess compressing the spinal cord. Neurosurgery is called emergently. Surgery is performed. But by this time, the window has closed. The patient is left with permanent paralysis from the waist down.
This is an extraordinarily difficult diagnosis to make, especially early in the course, before focal neurological deficits have developed. And by the time those deficits appear, recovery is already less likely. The data supports that a 56% diagnostic error rate does not describe a diagnosis that physicians are routinely expected to catch on the first encounter. So, what are we asking for here? We are not asking you to diagnose every epidural abscess on presentation. We are asking you to identify the patient who is at higher risk for something more serious than a strain and to spend a few more minutes with that patient. Ask a few more questions, look for the subtle clues, risk stratify before you finalize the diagnosis. It is hard to fault the physicians in these cases, and that is not the goal of this episode. The goal is to ask the question, how might we identify this before the neurological deficits have developed?
At trial, the emergency physician from the first visit was cross-examined about the MRSA history. The plaintiff's attorney directed the physician to the chart entry documenting the staph skin infection 2 weeks before the back pain presentation. Doctor, you see here in the chart, 2 weeks before this visit, the patient had a staph skin infection. Is that correct? Yes, I see it. Would you have ordered an MRI if you had known about that? And the physician answered, yes, I probably would have.
That answer is worth spending a moment on, and because it teaches something about deposition and trial preparation that goes beyond this case. The MRSA skin infection alone may not be the obvious trigger that leads any of us to order an MRI. In a patient without signs of active infection, no fever, normal white count, no focal deficits, the MRSA history is a risk factor, but it is not the same as a clinical indication for emergent imaging. If I were asked that question, I would want to have thought about it carefully before the deposition. I might respond that the MRSA history would have played a role in my differential and my workup, but that in and of itself, without signs of infection, it would not have made me order an emergent MRI. That is a more accurate answer. And it is a more defensible one, because once you say, yes, I would have ordered it, you have acknowledged that you did not review a critical piece of information that was in the chart, and you are going to have difficulty recovering from that admission. That is not hindsight. That is preparation. Discuss these questions with your attorney before you sit for a deposition. Think through how you would answer them. A nuanced, honest answer is always better than a clean concession that hands the plaintiff their breach argument. And here is a broader principle for any deposition. Always take a moment before you answer. Ask yourself, why is the attorney asking this question? What answer are they looking for? A few seconds of pause to engage your analytical thinking instead of giving a reflexive answer can make a significant difference. You are under oath, you cannot omit or mislead under direct questioning, but you can give a measured, thoughtful response that does not concede more than the facts require. That comes from preparation, not improvisation.
And that is exactly the dynamic at work here. The physician's own testimony established breach. Once the defendant acknowledges that the standard of care required something they did not do, the defense has lost that element. Plaintiff experts can define the standard of care around the appropriate imaging modality in a patient with identified risk factors. And that is exactly what happened. The jury returned a verdict of $5.6 million. Medical malpractice requires 4 elements. Duty. The physician owed the patient a duty of care, which is established the moment they're seen in the emergency department. Breach. The physician failed to meet the standard of care. Causation. That failure caused the patient's injury. And damages. The injury resulted in measurable harm. Spinal epidural abscess cases are among the most plaintiff-favorable in emergency medicine malpractice. 2 peer-reviewed analyses, one by DePass and colleagues in the Journal of Neurosurgery, Spine reviewing 56 cases, and one by Shantaram and colleagues in Orthopedic Reviews reviewing 135 cases, found plaintiff win rates of 30 to 35%. For context, the typical plaintiff win rate in emergency medicine malpractice is about 7%. Mean plaintiff verdicts range from $4.3 to $5.3 million. Mean settlements from $1.9 to $2.3 million. Defense verdicts occur in approximately 40% of cases. But when the plaintiff wins, the damages are severe, and the DePass analysis found that diagnostic delay was significantly associated with plaintiff verdict. Paralysis or quadriplegia, as the outcome was also significantly associated with both plaintiff victory and higher monetary awards.
I am passionate about this diagnosis because I was a defendant in a medical malpractice case related to an epidural abscess. I went through that chart again and again, interrogated it, trying to find the obvious clue I was missing, the clue that should have led me to the diagnosis, and I could not find it. There were no focal neurological symptoms, no fevers, normal white blood cell count. The only potential clue was a minor surgical procedure a few months before the patient came under our care. I was involved in the first medical visit, but when that patient returned weeks later, the presentation was dramatically different. Permanent deficits. I still have a hard time seeing what I could have done differently, but I still carry some of that weight, the feeling that I missed something that was alleged to be there. Since that case, I have approached back pain differently. Almost with a defensive medicine mindset, if there is any new or evolving back pain that does not fit a clear pattern, I have a lower threshold for imaging. And I know we should not practice defensive medicine. But here is what happened. Because this diagnosis was on my radar, I have caught a few epidural abscesses early enough that intervention could be performed before permanent neurological injury set in. Colleagues and I used to joke that I might be a magnet for this diagnosis, but after a while I started to wonder, are we just not catching them because they are not on our radar? I was catching them because a lawsuit put them on mine.
The specialty distribution is important for our audience. Internists and hospitalists are the most commonly sued physicians in spinal epidural abscess malpractice, 14.8 to 23% of all cases. Emergency medicine follows at 8.9 to 14%. The liability falls overwhelmingly on the physicians responsible for initial evaluation and diagnosis, not on the surgeons who ultimately treat the condition.
And I think that reflects what makes clinical sense from a medical malpractice standpoint. The heaviest liability falls on the physician who releases the patient from medical care, the emergency physician who discharges the patient, the hospitalist who writes the discharge order. To be clear, we are talking about liability in the legal sense. Clinically, a discharge can be appropriate based on what is known at the time, but if the case reaches a courtroom and objective data would have supported further workup, the discharging physician is the one who bears the scrutiny. If you are admitting a patient or picking up a patient on your service for back pain, that should cross your mind. You need to do your due diligence and make sure this is not something more serious than a disc herniation or a muscle issue or arthritis or whatever other benign process it likely is. Once you discharge that patient, you can and likely will be the physician whose decision-making is examined most closely if a medical malpractice claim is filed.
The clinical data on diagnostic delay and outcomes is consistent across multiple studies. Davis and colleagues, in 2004, found diagnostic delays in 75% of SEA patients. Among those with delayed diagnosis, 45% had residual motor weakness, compared to 13% without delay. That is an odds ratio of 5.65. Young and colleagues in 2023 demonstrated that surgical decompression within 24 hours of imaging yielded the best neurological recovery. Delays beyond 72 hours effectively negated all surgical benefit. Boss and colleagues, in 2018, found that surgery delayed beyond 12 hours after clinical diagnosis produced significantly worse outcomes, with an odds ratio of 4.5.
What those numbers describe is a closing window, and the difficulty is that the window does not announce itself. A patient can go from back pain, intact exam, to progressive weakness, to irreversible paralysis over the course of hours, not days. The rate of progression in spinal epidural abscess is unpredictable. That is the clinical reality that makes early diagnosis so critical. You cannot wait for clinical deterioration to trigger imaging because by the time deterioration is apparent, the window may already be closed. The VA study by Bies and colleagues, 250 patients, found that when diagnostic error occurred, the median time to diagnosis was 12 days. When there was no error, 4 days. That 8-day difference is the difference between walking and not walking. And for many of those patients, the delay was not a single failure. It was a series of encounters where the threshold for MRI never lowered.
When you analyze the malpractice case record across multiple studies and multiple decades, several failure modes recur in spinal epidural abscess litigation. First, failure to have the diagnosis on your radar at all. Spinal epidural abscess needs to be somewhere in the back of your mind when you are working through back pain patients, particularly those with risk factors for bacteremia. If the diagnosis is not on your radar, none of the downstream steps happen. Second, failure to order MRI. This is the most common breach alleged. CT is consistently inadequate for detecting epidural abscess, yet physicians frequently order it instead of MRI or order no imaging at all. And as we discussed, ordering the wrong test is not neutral. It timestamps the moment you were concerned enough to image, but did not order the study that could have answered the question. It becomes a powerful plaintiff exhibit. If the physician had ordered the correct exam at that exact moment, the outcome may have been different. Third, failure to include SEA in the documented differential diagnosis. Physicians attributed symptoms to musculoskeletal strain, degenerative disease, or disc herniation without considering infection. Fourth, premature discharge from the emergency department without adequate workup. Multiple visits before diagnosis is the most common case narrative. Fifth, failure to act on abnormal laboratory values. Elevated white counts, ESR, CRP, or positive blood cultures were documented in the chart but never connected to the clinical picture or used to trigger imaging.
On that fifth point, blood culture, results deserve specific attention. On the inpatient side and in the emergency department, it is critical that your hospital has a process for alerting patients when blood cultures return positive after discharge. That is a significant liability for both the patient and the healthcare system. If cultures come back positive after a patient has gone home, there needs to be a process for immediately contacting that patient and directing them back to the emergency department. That system cannot rely on individual memory. It has to be built into the workflow. I have seen a nuclear verdict from a case where a positive culture never made it back to the patient, and we will cover that case in more detail in our On the Record series.
Sixth, failure to transfer when MRI was unavailable at the presenting facility. Courts have treated this as a clear breach when spinal infection was clinically suspected. And seventh, radiologic misinterpretation, reading CT as negative when MRI was indicated, or imaging the wrong spinal levels.
I have seen that last one more than once, lumbar spine imaged with MRI and read as negative while the lesion was in the thoracic spine. Epidural abscesses can have skip lesions. That is why, when the concern is present, the recommendation is full spine MRI with gadolinium, not single level, full spine. If you read those failure modes as a list, they look like independent problems. But when you see them in the clinical record, they form a cascade. The physician anchors on a benign diagnosis. Because the diagnosis is benign, advanced imaging is not ordered. The patient returns, but instead of revisiting the initial workup, the return visit looks for a different cause of the pain. You might, in this case, a kidney stone, and when that workup is negative, it inadvertently reinforces the original assessment. Labs may come back abnormal, but they are not connected to the clinical picture because the differential never expanded. By the time neurological symptoms appear, the delay has accumulated across multiple encounters. It is a system failure as much as a cognitive one. And there is a tension here worth naming. There is a legitimate push in emergency medicine right now to reduce unnecessary imaging for benign back pain, and that is a good cause. Quality metrics are tracking CT utilization in back pain presentations, and the goal is to avoid radiation exposure and cost for patients whose pain is overwhelmingly musculoskeletal. But this is the case where imaging needs to happen, and when it does, it should not be a CT. When risk factors are present or clinical suspicion is elevated, the right study is MRI. The metrics designed to reduce unnecessary imaging in low-risk patients should not discourage necessary imaging in high-risk ones. Those are different clinical populations requiring different decisions. We need to talk about attribution bias. This is the tendency to explain a patient's symptoms by reference to their social history rather than organic disease. And it operates most powerfully in patients with substance use disorders. Clinicians are aware that some patients with opioid use disorders seek care for pain that is motivated by substance dependence rather than acute pathology. That awareness is grounded in clinical experience, but over time, that experience can subtly become a bias, and not everyone recognizes it happening. The differential in a patient with IVDU and back pain should raise concern for epidural abscess. That should be high on the list. But in practice, it can be easier to dismiss the symptoms, to attribute the presentation to drug seeking or some other secondary gain. And that is where we unintentionally create patient harm and significant liability for ourselves. IVDU is one of the strongest risk factors for spinal epidural abscess. It is present in 20 to 33% of all cases. IV drug users have a much higher risk of low-level bacteria seeding into the bloodstream. Staphylococcus aureus, the organism responsible for 60 to 70% of spinal epidural abscesses, is the dominant pathogen in IVDU-related infections. The same social history that can trigger clinical skepticism should trigger clinical vigilance. And these patients may have a more low-grade bacteremia, no dramatic fevers, no markedly elevated white count. The presentation can be insidious, which further compounds the complexity of the diagnosis. And this bias is not limited to IVDU patients with back pain. Think about the young patient who presents with a headache or altered mental status, and the assumption is intoxication or withdrawal ictera. Without a thorough examination, the stroke or the bleed gets missed. Or the patient in the emergency department whose altered sensorium is attributed to substance use when it is actually sepsis or a metabolic emergency. This happens more than we would like to admit. The call to action here is broader than spinal epidural abscess. Walk into every patient's room with a clear head. Examine first, anchor second, not the other way around. Watari and colleagues studied the cognitive errors physicians identified as their most memorable diagnostic mistakes. The cases that stayed with them. They found that premature closure, accepting a diagnosis before it has been adequately verified, was present in 58% of those cases. Premature closure means settling on an answer before you have finished asking the questions. The emergency department was the most common setting, with nearly 4 times the odds of cognitive bias contributing to the error compared to other settings. Saposnik and colleagues found anchoring, the tendency to fix on the first diagnosis and filter subsequent information through that lens, associated with diagnostic inaccuracies in 36 to 77% of physician case scenarios. These are not rare cognitive events. They are the default mode of clinical reasoning under pressure, and attribution bias compounds them. It provides a reason to stop the diagnostic process. In the case we discussed today, the MRSA history was an IVDU-associated pathogen. It was a direct indicator of bacteremia risk. And the point I want to make is broader than this one case. MRSA history, IVDU, and back pain. That combination should put spinal epidural abscess very high on your differential, but it is not limited to IVDU. Any condition that predisposes to bacteremia should raise the same concern. Immune deficiency, chronic intravenous access from PICC lines or ports, surgical intervention with infected hardware, chronic wounds, Decoupes ulcers, for example. Hemodialysis access. If the source for bacterial seeding is there, the risk of spinal epidural abscess is elevated, regardless of the patient's social history. There is a framework worth knowing about. Davis and colleagues published it in 2011 in the Journal of Neurosurgery. Spine, it has been prospectively evaluated, though at a single center, and it has not been adopted as a formal standard of care by any major medical society. But as a suggested approach for screening and imaging these patients, the reported outcomes are worth attention. 3 steps. Step 1, screen. Every patient with spine pain gets asked about risk factors, intravenous drug use, immunosuppression, recent spinal procedure, indwelling catheter, recent infection, diabetes, chronic kidney or liver disease. Step 2, labs. If any risk factor is present, order an ESR and a CRP. These are not expensive tests. They return in about an hour at most facilities. Step 3, image. If ESR is elevated or CRP is elevated, order emergent MRI, full spine with gadolinium, not CT, not single level. Full spine because epidural abscesses can have skip lesions. When this framework was implemented prospectively, diagnostic delays dropped from 84% to under 10%. Motor deficits at diagnosis dropped from 82% to 19%. Those are notable numbers from one protocol change. It has not been adopted by any major medical society, which means it is not a mandated standard, but it provides a useful pathway to screen and image these patients. And it is the best available evidence we have. The screening bridge is the ESR and CRP. Combined, when both are normal, ESR 20 or below and CRP 1.0 or below, they achieve 98.9% sensitivity with a negative predictive value exceeding 99%. That means if both are normal in a patient with risk factors and an intact neurological exam, you can more confidently pursue a musculoskeletal diagnosis. The labs give you a defensible off-ramp. One caveat: the framework only works if you apply it, and applying it requires asking about IVDU, asking about immunosuppression, asking about recent infections. If unconscious beasts about the patient's social situation has already led you to dismiss the presentation, whether that manifests as assuming drug-seeking behavior or simply not engaging fully with the clinical picture, the protocol never fires. The framework is a tool. It does not override the cognitive process that decides whether to use it. And on that point, how you ask matters. When you are screening for intravenous drug use, the way you ask the question affects the quality of the answer you receive. If a patient feels judged or shamed by the question, they are less likely to disclose accurately. And that missing information can cost you clinically and legally. Ask in a non-judgmental, matter-of-fact way. Frame it as part of your routine assessment. I ask all my patients about this because it affects the medical decisions I make for you. I usually explain a specific scenario where it would help my decision-making, and this case is a perfect example. I would say the reason I'm asking is because if you do or occasionally use V drugs that can increase the risk, and there are specific tests I need to order. The goal is information that helps you protect the patient. You cannot risk stratify with incomplete data.
On the documentation side, there are 5 elements that create a defensible record when evaluating back pain. First, document your red flag assessment. Did you screen for fever? Did you document IVDU history, prior infection, immunosuppression. If it is in the chart and you did not read it, the plaintiff's attorney will find it. If you read it and documented that you considered it, you are in a different position entirely. Second, document a neurological examination with specific findings. Motor strength, bilateral lower extremities, sensory level, reflexes. Neuro intact is legally insufficient. It does not demonstrate that the physician evaluated for the specific emergent diagnosis. Third, if you order inflammatory markers, document why. If you do not order them and risk factors are present, document why not. The reasoning matters. Fourth, include a sentence in your medical decision-making that explicitly addresses spinal epidural abscess. This is important, especially in patients at higher risk. Considered spinal epidural abscess, ESR and CRP normal, neurological exam intact, no fever, SEA effectively excluded. That sentence demonstrates deliberate clinical reasoning. It is powerful evidence of standard of care. Fifth, return precautions must specifically mention neurological symptoms, not return if worse. Instead, return immediately if you develop leg weakness, numbness, or difficulty controlling your bowel or bladder. Specific precautions show that the physician considered the serious diagnosis and communicated it to the patient. Though it is worth noting, in the case we discussed today, the patient did return to the emergency department as instructed. Discharge instructions alone do not protect you if the workup on presentation was inadequate.
For hospitalists managing admitted patients with back pain, or patients who develop new back pain during a hospitalization, serial neurological examinations every 4 to 6 hours are both clinically protective and legally protective. Any change in strength, sensation, or reflexes triggers immediate imaging and surgical consultation. Document each exam. The serial record shows ongoing vigilance. This can happen especially in patients with prolonged hospitalizations. Be vigilant for any new symptoms in a patient who has been in the hospital for an extended stay. And when you order serial neurological exams, take a moment to discuss the reasoning with nursing. Explain why you are asking for them. Nurses are at the bedside far more consistently than we are, and they tend to notice changes that we might miss on a single rounding encounter. When the nursing team understands the why behind the order, when they are actively engaged in watching for a neurological change, they become your most reliable early warning system. That team communication is part of the clinical process, and it deserves the same attention as the order itself. Here is the one thing I want you to take to your next shift. Back pain in an IV drug user should trigger you to look for spinal epidural abscess and prove that it is not the case. That framing changes the algorithm. You are not asking, is this musculoskeletal? You are asking, have I excluded SEA, ESR, and CRP first? If they are elevated, think emergent MRI. If they are normal and the neurological exam is intact, you have a more defensible clinical decision and a more defensible chart. But you have to ask the question first, and you have to ask it even when, especially when, attribution bias is telling you that the patient is there for something other than an emergency.
From the legal perspective, the standard of care now includes risk factor screening. If inflammatory markers are elevated and you do not image, the plaintiff will present expert testimony that this was a breach. Verdicts in these cases average over $4 million. Internists and hospitalists bear the greatest share of liability. The prevention is a screening question, a blood test, and an imaging protocol. The barrier is making sure you actually do it.
That is the cognitive autopsy for today. A diagnosis missed not because the physician lacked knowledge, but because information alleged to be integral to the case was buried in the chart from a previous visit. Because the cognitive habit of back pain equals musculoskeletal was never interrupted by the risk factors that should have prompted a different question. Thank you for listening. I am Brian, with Sarah and Paul. This has been The Cognitive Autopsy from the Charted Defense. This content is produced for educational purposes only. It does not constitute medical advice or legal advice. The clinical and legal information presented reflects publicly available case records, peer-reviewed literature, and published guidelines. Laws vary by jurisdiction. Clinical decisions should be made based on individual patient circumstances and current evidence-based practice. Case details are drawn from public court records